long now, Randy. Hey, you're on Lunch Conversations with Randy and Teddy, and you don't need to worry about where I am, but I am safe. And I am also doing this legally. So thanks for showing up today. For those who don't know, I'm Teddy, and the other guy with the shiny head is Randy, and the other dude is Dan Leonard, and we'll tell you about him in a minute. But before we get started, we need to thank Blackwell Captive Solutions for being our sponsor. We appreciate all that they've done for us in the first half of 2023 to make this show a success. Blackwell Captive Solutions is they help organizations who are self-insured, who self-insure their health care for their employees, put a stopgap loss, which I never really knew what that meant, but now I get it. Stop loss gap protection in there to protect against those sometimes high insurance claims that their employees have. So reach out to Blackwell Captive Solutions if your company is self-insured, specifically for healthcare insurance, and have a conversation with Carrie and her team. I can promise you that it'll be enlightening. So let's see, I think I'm all good to go. Again, for those who've never met me, I'm Teddy. I'm a LinkedIn strategist, trainer, and coach. I help business professionals all across the freaking globe. Can I say freaking, Randy? I think I can.
I think you just did.
Yeah, I just did. So love it. Burriss Consulting helps organizations, B2B. We do webinars, seminars, corporate training programs, one-on-one coaching. We will hold someone's hand while they're getting married and help them change their LinkedIn profile when they need to change it before they get married. But anyway, enough about me and my shenanigans. Boom. Randy, would you introduce yourself to our audience?
Yeah, Ted, I appreciate it. And we were up and running on LinkedIn and Facebook, so all good. I'm going to check that box. So we're all good to go there. But yeah, Randy Wooden with Goodwill Industries of Northwest North Carolina, director for our professional center. Yeah, we have a professional center. It's in Winston, and happy to help you. Clients across the country. And best of all, we're free. So if you or maybe you've got a child graduating from college and looking to move back home and you're thinking, not sure I want to go that route, then reach out to me. We'll get them on the calendar and try to help them get where they want to go. But every Wednesday, Teddy and I get together for an hour and we learn stuff. Sometimes about job hunting, sometimes about business, sometimes just about things that are curious to us. And I'll tell you, this is a topic that I don't know will go away in my lifetime, and that is the cost of healthcare. How the heck did it get to be so out of hand? And is there anything we can do about it? And what's really driving all this stuff? And so I reached out to an old friend from college, Dan Leonard, and we'll get into Dan's background here in just a bit. But some of the topics that we'll cover today deal with this whole healthcare issue. We're going to introduce a couple of terms you may not have heard of, at least one of them anyway. I had never heard of. It's called pharmacy benefit managers. So we'll learn what they are and their role in this whole mess that we're in. Also some other things, too, that Dan has come across in terms of some new innovative ways of delivering healthcare and so forth. So we'll get into all that. Teddy, I see you want to jump in.
I want to make sure you realize, Randy, we do not call our special guest old.
Okay.
It's not polite, dude.
He's younger than I am, so he can call me old. Hey, by the way, if you have comments or questions for Dan, put them in our chat box. Teddy will keep an eye on that. And unless I've left something out, Teddy, I'll throw it back to you, and we can get this started.
Well, I think we're good, man. I think
you're good to go.
They know who I am. They know what I do. Okay. I did my ad spot. I'm on top of my game, buddy.
All right. Well, Dan Leonard, straight from Washington, D.C. area?
Suburbs, yeah, Maryland.
Maryland, got it. Yeah. I've known Dan for longer than either of us probably care to remember. Yeah. But Dan's had a great career, and it spans everything from being a television reporter to getting into the healthcare arena, the insurance arena, pharmaceuticals, and he's currently the principal of Granite Capital Consulting. So, Dan, welcome to the show.
Well, thank you, Randy. Thank you, Teddy. It's good to be here. I appreciate it very much. It's going to be fun.
Tell us a little bit more about your background, a little bit more detail, and then we'll get into the topics today.
Yeah, so we got to go to the Wayback Machine, and as you know, Randy, we went to college together, and at that point in my life, I was studying to be I was a journalism major in college and studying to be a reporter. And we at our little college, we had a pretty decent television station and a couple of radio stations. And
Yeah, we did.
both Randy and I spent a lot of time in the basement of one of the buildings there working on the precursor to podcasting, radio shows and TV shows. And that's what I did when I got out of college. Worked in a couple of newsrooms in Boston and Pittsburgh, and then went back to my home state as a reporter in New Hampshire. And where I was working was the only station in the state. And in New Hampshire, they have this weird circus every 4 years called the presidential primary. And so I got the political reporter left, and the news director said, "Who wants to be the new political reporter?" And I raised my hand, and no one else did. So at 24, I was the political reporter covering the next president of the United States. And we knew one of these folks was going to be president. So I interviewed all of these candidates. This is 1988. So this is going to give you a little clue on how far back we're going. But that was essentially my full-time job for the year leading up to the New Hampshire primary. It was just covering all these guys: George Bush, Bob Dole, Jack Kemp, Mike Dukakis, Jesse Jackson. The list goes on and on. And then when the circus left town, I got a case of withdrawal, which is fairly common in high intensity jobs of any kind, where you do something repeatedly really hard for a period of time. And then so I was like, well, the circus left town. I went to my news director and said, I'm ready to go to Super Tuesday. I'm going to go to South Carolina, down to Georgia. And he said, "No, you're not. You're going to Concord because they're going to raise the parking meters by a nickel." And
so the whole media thing kind of it ran its course, and then you said, "Hey, wait a second, I'm going to pivot a bit here." So you got more into the political side of things, and that more.
Yeah, I think it was this part of this withdrawal. I was really intrigued by the politics. Got to know a lot of the campaigns. I obviously knew the state representatives, and I was asked to come be a press guy for a congressman who was running for Congress at the time. And I did. I left TV, and the TV didn't pay anything back then. And the promise was to go to Washington. So I did my job, and we went to Washington, and I really pivoted to Capitol Hill and worked on Capitol Hill for a number of years, and worked for different members, and then became a chief of staff for a member of Congress from New York. And worked in campaigns, and that was all exciting. And then I was ready to pivot again, and I went to the communication side of corporate, right? So a couple of public relations firms in DC, handling public affairs and some government affairs lobbying. And that's where I got introduced to trade associations. And then I spent the last 20 plus years in trade associations, and we can dig more into that too. But.
So I always ask the why question, and you're obviously, you've been in it a long time, knee deep in this stuff for a very long time. You got to have a passion, a drive to keep at it all these years. What's your why?
Yeah, so I have to break up the why again based on these chapters that I've had in my career, because the why coming out of college was very different than what it has been, over the last several actually. So back then it was. I wanted to tell stories. I was always, I guess at the heart, I've been a storyteller. So I wanted to tell stories, and now you can tell stories on YouTube or on a podcast, but back then it was basically the newspaper, radio, or TV. And so I wanted to be a storyteller, and I liked the idea of television. So I got into news coverage, covering the news. And then, through that experience I just outlined on politics, was, being in the room and helping to shape decision-making, shape policy. So that was the early phase of my career. When I got into healthcare, when I think about healthcare and where I've worked in healthcare, I come back down to the word access, and access to quality healthcare for patients. Yeah, and access means different things to different people in the corporate sense. So if you're working at a health plan or for the health insurance industry, as I did, access was all around making sure that you had a card in your wallet that said you had insurance. At those days, there were 40 million Americans who did not have insurance. So we did a lot of work to make sure that folks got insurance. So that was access. when I went to brand pharma, it's all about making sure that the drug that you have developed is on a formulary so that that patient can get that drug, access to the medication. Because and then when I moved on to the generic drug industry, it was all about affordability and making sure that patients could afford the drug, because if they can't afford it, then access doesn't really matter. So this term access has had a theme in my career over the last 20 when I've been in healthcare.
Yeah, it makes sense. So, yeah, there are a lot of tentacles with this. And by the way, if you have comments or questions for Dan, put them in the chat too. Keep an eye on that. All right. So you mentioned associations. What role really do they have? Why are they important? You spend a ton of time in different associations. Help us understand their role in this whole matrix of healthcare.
Well, first, I'll back up even more and just say that associations in general, because not everybody understands the role of an association or just how prevalent they are. They are, at the core in Washington anyway. They're the advocacy voice for the industry or for a professional society. And I would say everything in life has an association representing them in Washington. So I want to make this more interactive with you guys today. So I would just tell you, look around your desk. What do you see? Pick one thing. If you look around, what the heck is that? Beer opener. Beer. Okay, he's going to crack open a beer. I love it. Well, the Beer Association is a significant one, right? So they have an association. Probably the metal definitely the steel industry, whoever made that device. Mm-hmm. You think about, a photo, there's the company that made this frame. So they would all band together and represent the frame manufacturers, the stores where that was sold, the photographers, the camera manufacturers have an association. So everybody has an association. Yeah. And their role is, to represent them in government and lobby on their behalf. That's what most people think of, but they do other things too. Big meetings, annual conferences, conventions, policy. Yeah.
Teddy, he got him so excited he lost
his voice.
There
is an association. There is an association of association executives.
Yes, there is. ASAE.
Yeah. Why am I not surprised?
Oh, there is. It's a pretty big one too.
Yeah. So they do more than just lobby then, right? So what are some other things that they do?
Well, and policy development. What are the policies that would help the industry? I mean, annual meetings, big meetings. Most industries have an annual confab or multiple meetings where they'll come together. Those are often put on or hosted by the association. What's interesting to me early on, I started in public relations and I had a couple clients who were associations. And then I thought, and people are of two minds. Either that would drive me crazy working in that environment, because the board table, and I've managed these boards for a long time, the people around that table are fierce competitors. They're trying to knock the teeth out of the guy next to them every day in the market. But when they come together under the antitrust kind of umbrella of an association, so there are legal reasons to have an association too. You have the ability to say things in that room that you cannot say to your competitors in the lounge at the hotel. All right, so there are protections there, but they're trying to advance the industry. If you think of the rising tide lifts all boats, that's what an association can do. And it is a little bit like herding cats, to use another phrase, but I guess I like cats. So I enjoyed working in associations for a long time.
And we're going to get into some of the nitty gritty kind of don't pay attention to that guy behind the curtain kind of thing. But before we get into the negative side, let's talk some positives. I mean, it's not all bad. The healthcare system in America, I mean, there's a lot. There's improvement to be made, but there's a heck of a lot of good stuff. Why don't we share a couple things that really stand out, a few things?
Yeah. I mean, I think it, we'll talk a lot about costs, and it is expensive, and it does cost more in this country than pretty much any other country in the world, our healthcare system. But to be honest, if I had a serious condition or, cancer, God forbid, any dread disease, I wouldn't want to be treated in any other country. We are the engine of innovation still to this day, and all of the new therapies that are coming out treatments, even the mechanisms for treatment devices, most of that innovation is coming out of this country. So that's a positive for this country. There's also, there are downsides to other systems. You've heard probably about single payer systems in Europe and Canada and elsewhere, where there are often long wait times to get treatment. I mean, if you have cancer, even you're put on a list and you have to wait your turn to get the treatment that you probably need right away. There's a lot of other things going on too. They measure the cost of healthcare in England, certainly as a quality adjusted life year. So that's another term for another day. But you can only get a treatment if it fits into this box, where it delivers the amount of care that fits this model that they have. And so it's different. There's rationing in those countries. So what we're seeing around the world, but it begins here, are the medical advances, new treatments, new cures, huge breakthroughs in treatment, and for very rare diseases and hereditary conditions that are coming our way. Hemophilia, we're very close to breakthroughs in hemophilia that will be just life-changing for people who suffer for that condition. But we can get into that. So there is a lot of good in our system, and then the people, just committed individuals, physicians, nurses. There's a shortage, man. You talk about your career as jobs. If you're giving advice and people are attuned that way, tell them, have them go into nursing, go into the medical care field, home care, because we need more people in those fields.
Yeah, I'll tell you that two areas where I've seen a lot of burnout here in the last few years. One is teaching. I mean, you don't have to be a rocket scientist. Yeah. So teaching is one, and healthcare, thanks to COVID and all the stress and pressure put on folks. There's a lot of burnout there. But you're right. I mean, if you want to be a nurse, you get a job anywhere in the country as long as you're licensed. So there's a lot of good there. All right. So this PBM. Pharmacy benefit managers. I mentioned that earlier, and you mentioned that in your talking points. So I'm not going to use the word bash, although I just did. But there are reasons why healthcare is expensive, and I got to say these guys are, if not at the top of the list, they can sure see the top. So help us understand who these characters are and their role in driving up cost of healthcare.
Yeah, I will, because they're not that well understood. But let's back, if I could, just back out even more, because healthcare is expensive. We're talking about the drug component of healthcare, but let me ask you guys a question. Where do you think the most money, Randy, is spent in healthcare? So if you think about the big chunks where healthcare money is spent, what's top of the pyramid?
Well, I'm going to guess the emergency room. When I go in for anything, if I have a nosebleed or a cough and I go to the ER, I think the cost of that care is probably the highest. But
let's ask
Eddie?
the audience. I mean, Dale's chimed in with his thought. Anybody else have a thought of where's the most? If I'm asking the question that Dan asked, right, where's the majority of the dollars spent? Where are they going in healthcare? Is that the right question?
Yeah, and if I break it down, even hospital care is one bucket. Physician and clinical care is another bucket. Prescription drugs is the third bucket. Of those buckets, how would you rank the spending in those three very large buckets?
I don't know. I guess pharmaceutical. I guess the cost of drugs and getting it to market. And
well, that's what a lot of people think, and that's where you would think that, because that's where a lot of the heat and light is in Washington on that industry.
Teddy, why don't you guess? Here, I keep coming up with the wrong ones. Why don't you try?
Well, so you're saying are you saying doctor, hospital, pharma? Is that what you're saying?
Yeah. Yes.
Yeah, I'm going with hospitals.
You're right.
Because listen, and I'm not an expert by this, but I see the stuff on TV every now and then and on the internet. I mean, the hospital organizations are behemoths. Now, pharmas are also behemoths. And a behemoth industry demands behemoth dollars.
Yeah. So you're right. And Randy, actually, you were on it right away, which was the emergency room care. But emergency room care is a piece of the larger bucket,
Yeah.
right? Hospital.
Okay.
$1.3 trillion spent in hospital-based care, inpatient and outpatient in 2021. These numbers are a year, had a lag, but 1.3 trillion. Next is physician and clinical care, 864 billion spent there. And then pharma, prescription drugs, 378 billion. So, big numbers, but again, because of what you hear from politicians, also, if you watch TV, you can't help but see drug ads. Sometimes they drive people crazy, people who've worked in the industry. Like
There's
myself.
a drug for that too, Dan.
Yeah, that's a good one. We should, sure there is. But drugs account for about 12% of the overall spend. Okay. So when we're talking about PBMs, we're talking about trying to get a handle on that relatively narrow slice of the overall piece of the pie. Okay. But your question was around PBM. So who are these guys? These are the men behind the curtain, the people behind the curtain. They are the middlemen who sit between an insurance company or an employer and the manufacturer. And they structure contracts with those employers and insurance companies to deliver, to get medicines to the members of that plan. And then they negotiate on the other side with the pharmaceutical manufacturer to provide the medication. And particularly in cases where there are multiple medications, they have authority and they have contract power. And the biggest problem is there are only 3 of them.
These are
monopoly. It's not a monopoly, but it's darn close because
these are the PBMs, right? These are the pharmacy benefit managers. So we're talking about pharmaceuticals here.
Yeah, three of them control 80% of the market.
Okay.
And so they have a lot of contract power. They have a lot of power, and so they can go to a manufacturer and say, "Well, you want this price, but I'm not going to put you on a formulary. I'm not going to cover your drug unless we work out a deal." And instead of just going to the lowest cost and saying low prices, and this happens in the generic space, but they'll often negotiate up and then extract a rebate out of the manufacturer that comes back to them. So you'll see higher list prices, and then a rebate that gets sent back to the PBM, and then the PBM can send it back to their employers, back to their customers, their employers, insurance companies. They don't send everything back. So a lot of it, ends up in their pockets. And those companies, the PBMs, are the fastest growing part of this slice that we're talking about right here.
So who put the PBMs in place? How'd that door get opened? Or is it the right door to have opened?
It goes back a couple, maybe 15 to 20 years. Insurance, the older insurance models where, and then often in the beginning, early days, drugs were not covered under insurance typically. And then they become covered under insurance, and the insurers would figure it out. But as more and more drugs came online, more patients needed medications, they carved it out and it became its own kind of business to just manage that negotiation between the manufacturers and and ultimately the patient and the pharmacy. And so that was created, but it just has been growing over time. Can I play another game with you guys?
Sure.
All right. So
what's the prize?
Yeah.
Dan, what's the prize today?
You get to look smart on TV. You get to look smart on this.
I've been drinking this. It's called Genius Water. In fact, here it's Teddy. I've got a ton of it if you need it.
But Randy, I told you that case was 20 years old, dude. This stuff doesn't work anymore.
This is Genius Water. So I just can't prepare today. Just to let you know. I'm sorry. Go ahead, Dan.
Well, I expect big things from you then. I expect big things. All right, here's the question. And your audience obviously can play in this too. Think of the Fortune 100. Everybody knows the Fortune 100, the biggest companies. Don't Google this, but what are name the top healthcare companies on the Fortune 100? Who are the largest healthcare companies in our country? Pick one.
Is Humana part of that?
Okay.
I don't know.
I don't know.
I have no idea.
Humana's number 40.
Well, they made the cut anyway.
Yeah,
that's good.
They made the cut.
Aetna, CVS, McKesson.
Right, CVS is the top. Is the largest. They're number 4.
Okay.
Healthcare, which is more than just pharma.
Well, that's the thing. So CVS is you think of them as your pharmacy, but they also own a PBM. They own the largest PBM. So you've never heard of Caremark they own a wholesaler. They own Aetna. So you mentioned Aetna. That's not a separate company. That's owned by CVS. So they're a conglomerate. This number 5 is the United Health Group, which is another conglomerate, which owns all the same, a PBM. They don't own a pharmacy, but they own tons of physician practices now. A lot of people say Pfizer, they say Merck, they say drug companies. The largest, Pfizer is number 43 on that list. This often surprises people that that companies, health insurance companies like Cigna and Elevance and Centene, Humana are larger than Pfizer. But anyway, that's kind of puts it in perspective that there are a lot of players in healthcare and there's a lot of money sloshing around, and big pharma is certainly big, but they are not the biggest players in our system.
And these healthcare organizations don't just play in one corner of the sandbox. They play in lots of different spaces to diversify their reach.
I think wasn't CVS from Rhode Island, I think originally. I don't know if they're still
headquartered there.
Still headquartered. There you go. Little Rhodey comes up big in the healthcare.
Very big.
Wow. I had no idea. I mean, there's a CVS and a Walgreens and whatever on every corner in town here, it seems like.
Well, you want to be they're number 4, as I said, but they're only behind Walmart, Amazon, and Apple.
Is that right?
Then CVS.
So are these PBMs? I think Teddy, you asked us how did they get to be these? Was there a legislative? I don't know. How did these things come to be?
Yeah, so there was this carved out need to kind of separately manage the drug benefit in health insurance benefit. So you have the medical benefit, which is paying your physician and your hospital treatment, your hospital care, but they carved out prescription drug services. And then that created this industry, if you will, the PBMs. And now, like I said, the PBMs are all owned by these big conglomerates. So there's 3. CVS owns the biggest one. Cigna owns another one called Express Scripts. And then Amerisource Bergen is another one. Optum is the 3rd, but they're part of United Health Group, right? So they're sitting inside these large conglomerates. And these are really the cash cows within these conglomerates. The PBMs are a pharmacy is not making money for CVS, very little. The PBMs are making significant revenue for the.
So now we got our half-hour break coming up here, but I'm wondering too, with these PBMs, do they get involved outside of pharmaceuticals alone and get involved in the hospital and deciding what it's going to cost if I have an appendix removed? And
no, they would not be part of the medical benefit, just the drug benefit.
Just the drug.
We'll get into that because
the anesthesia that you're going to have to get your appendix removed, yes, but not the procedure.
Okay, but we'll get to some of that stuff too about the cost overall of healthcare and what are some ways that we can hopefully keep an eye on it and minimize it.
Do your break, but we can get back into the PBMs
and maybe more. Maybe you can tell us what Chan's talking about in the context of the Amazon pill pack. So, hey, you're on Lunch Conversations with Randy and Teddy. Our special guest today is Dan Leonard. Dan's coming to you from around the Washington, D.C. area where I am hiding today. The show is sponsored in part by Blackwell Captive Solutions. They're great people. They align with this whole conversation because they're health insurance, medical stop loss captive, helping organizations who are self-insured with their medical insurance for their employees put that shock absorber in place for those high dollar claims. Look, if you're associated with an organization that is self-insured for medical costs, reach out to blackwellcaptive.com and have a conversation with them. Let them know that Teddy said to say hello. So, there are lots of different moving parts in this whole industry, Dan. Sometimes it can get quite confusing to pay attention to it. Randy, pick us back up, buddy.
Well, I just wonder, now that you've kind of opened this whole can of worms, and now we know who these folks are that are kind of playing with our costs here, I've got to think that politicians and associations, lobbyists, and others are banging on the door and saying, "Wait a second here, we've got to look at this thing." Help us understand how that dynamic is working at this point. Are we partway through this thing? Are we making any headway, or what?
It's been an issue on the Hill for years, but it does feel different this year. It feels like the forces aligned toward transparency are stronger than they have been.
Yeah.
There have been hearings recently within the last few weeks where the CEOs of the PBMs have had to come before Congress, and they've had a tough time of it, let's put it that way, because they're tough questions and they don't have very good answers. Mm-hmm. So there is momentum behind, some fixes. But here's another, I think, illustration that will help folks understand the role they're playing. So again, there's only three, and it's this market power that makes this makes this such an issue. There used to be dozens of them, and then consolidation has got really down to three. Three control 80% of the market. Mm-hmm. And where there are multiple drug companies, they have all this leverage. So if you think about a big drug company, Janssen Pharmaceutical, for example, Johnson & Johnson, one of the biggest. Next question: what percentage of the drug's price, if the drug costs $1, how many cents are going to the manufacturer, to Janssen, versus the PBM and the middlemen and everything else? Anyone? Take a cut. Come on, Randy.
All right, I'm going to say the manufacturer probably doesn't get as much as we would think. So I'm going to guess that they may only get like 8%. Right, 18.
Say they get 20-some%.
Yeah, well, it's 58. This particular company, Janssen, 58% went to the middleman and 40 went to the manufacturer. Another company, Novo Nordisk, who makes diabetes medications, 75% went to the middleman, about 25% back to the manufacturer. So that just means there's a lot of money in that middle space that's being moved around and controlled by the PBMs.
Wait. You said, you said 75% as an example of diabetes.
75% to the middleman, 25% to the
middle, the PBMs.
To the PBMs,
but
and then
the PBM,
the insurance gets a piece, the pharmacy gets a piece, but it's being
divvied up by the PBM.
Yeah,
I got it. Yeah, so he doesn't get it all. He gets 75%. And he has to divvy it up between the pharmacy. He has to divvy it up between
the insurance company. The patient often pays co-pays that gets wrapped into that too.
What is preventing there being new players in the field of PBMs? I mean, I get it, the consolidation happened. Same thing with Bell, the phones, the Bell systems, and
nothing is other than it's the market power of the incumbents. Put it that way. So you mentioned Teddy mentioned PillPack. That's another company that's in the space. There's one you may have heard of, a guy named Mark Cuban, the Shark Tank guy. He's got a company now that is called the Mark Cuban Cost Plus Pharmacy, where they'll buy medications, particularly generics, and mark them up 15%, but it's operating outside of the PBM. There are a number of those companies. Another one, Scriptco, that I know pretty well. The problem is it's really hard to crack the incumbents, and mostly because these deals are with large employers. So if you work for a large employer, your employer, and you're getting your insurance through your employer, they're working with these the big three. So there are good solutions out there. I'm rooting for them, but it's really hard to knock the incumbents off the horse.
Wow. Anything else on the whole PBM topic? Anything we should have asked you? Thing you want to talk about?
Even in the generic space, most recently I was the CEO of the association representing the generics and biosimilars, which are follow-on biologic medicines. Even there, where the medicines are very inexpensive, we're talking pennies a pill, very, very affordable. They're impacted by these conglomerates as well, because the wholesalers who buy in bulk the generics are also owned by the big three. And they can, this is a problem where, again, 3 buyers, but you might have a dozen manufacturers, but unless you get one of those contracts with those big three, you're kind of out of luck. So the manufacturers will, drive the price down, which is typically a good thing, until you have a situation where there's only one provider or one supplier, and then maybe you hit a supply chain issue. You'll hit, like we have seen recently, it's creating shortages in many generic medications, including drugs for cancer and chemotherapy treatments, where there's down to 1 or 2 suppliers, and then a supply chain issue will hit, and they can't meet the demand. So companies are literally going bankrupt. There was just in April of this year, a generic manufacturer that provided a number of cancer meds, low-cost cancer meds. They couldn't make a go because they weren't getting reimbursed at a rate that was sustainable. They went bankrupt, and now you have 6 critical chemotherapy medications that are not available to patients, and physicians are scrambling.
Can there? I don't understand how the industry works, but could another company come in and essentially buy that brand and manufacture it? And like,
yeah, I mean, they will try to sell those assets off. I'm sure they're doing that now, trying to sell off those licensed assets. That
takes time, though. Yeah.
And other companies could come in, but again, there's investment in manufacturing facilities, investment in redoing the lines to create those medications. It doesn't happen overnight.
Got to ask you, when I watch on television, you'll see tons of ads for, I'll call those name brand, even though I can't pronounce half of them, but name brand drugs. So those are the ones that cost a lot of money. And you mentioned something to me the other day. We were on the phone that if you look at, let's say, a pie of 100%, how many drugs are actually the high-end drugs, the name brand, and what does that account for dollar-wise in the overall spend versus generics and the overall spend?
Well, let's ask Teddy, because I think you know the answer, but what percentage of prescription medications, Teddy, are generics or low cost generics
versus the
brand,
big name brand. So let's put it to our audience. What percentage of the drugs dollars are spent on generics versus dollars spent on big name drugs?
Not the dollars. Let's break it up. So the volume. Let's take volume first. So if a billion prescriptions are let every year, what percentage of the volume are for generics?
And Dale's talking my numbers. I'm thinking the majority are going to be generics, and the minority is going to be the name brands.
That's true, but maybe higher than you think.
And Dale came from that industry, by the way.
Got it. It's now at 90%. 90% of prescriptions filled are generic. 10% are the ones you see on TV, brand medications. Innovative medicines, all great, good medicines. And in their early years, when they're patented protected, that's why they cost more. But that's only 10%. So 90% are prescription are generics. But what percentage of the spend?
Well, it's not going to be the same ratio, that's for sure. So I'm going to think 30% of the spend is on name brands.
87% is on name brands.
87?
12% on generic. So 90% of the drugs at 12% of the cost. Okay. Yeah. So that means 10% of the drugs are driving 87% of the cost. But again, those are innovative medicines that they're new to market. They're providing cures and treatments, and over time they will be replaced by lower cost medications. So it's the way the system works, and it works pretty well. But all of the costs that we're talking about when we're talking about drug costs are really packed into the that relatively small portion of medications.
I
Because
think-
those are,
yeah.
because we need those to be able to figure out what's the next, you know, they're, yes, they spend all the money in all the R&D, they get the early dollar, and then the
Exactly.
generics come back and they capture the, you know, the continued dollars. Am I saying
Yes.
that right?
That's exactly right. And that's the way the system is designed. And it works pretty well. And, you know, government, you know, tries to get in there and kind of retool the Hatch-Waxman law is what created it. And that typically leads to more problems than solutions. But there is, you know, it's really important that we have these innovations. And yes, it costs a lot of money to bring these new treatments to market. You know, for every drug that comes in, there were 12 that didn't work. Yeah. So you know, it's trial and error, it's R&D, it's a very expensive clinical trials. So there's a lot that goes into it. Those companies need to recoup that cost. And then again, over time, generics will show up. And
now Dale dropped in the 17-year number. Is when you say over time, is it 17 years, those kinds of numbers, or is it a shorter window?
Well, it would be nice if there was an easy answer to that. You know, should be what 10 years, but it isn't. There's different time frames, and you know, at the low end, you know, it's 7 to 10 years, but usually they extend. So there's an example, maybe one you've seen on these commercials that Randy watches on TV. Humira, have you heard of that one? So Humira is a great drug for rheumatoid arthritis and now a number of other treatments. But their initial patent went from 12 years. They're now in year 21. They keep getting extended. They petition or in lawsuits, actually in court to extend their patents. This year, 2023, that patent for Humira opened up, and so now we have, I believe, 2 biosimilars are on the market competing with Humira. 6 will be here before the end of the year. And we'll see, you know, costs coming down. But here's back to the PBMs. Here's another, you know, bizarre component of the PBM world. We've seen here in this case in Humira and in insulin as well, where manufacturers will produce the same drug and name it 2 different things and charge 2 different prices. One, they will, you know, they'll drop the price 50% off of or more off of what that name brand company sells it for. Another one, they'll only drop 5%. Which one do you think is getting more coverage by the health plans? The one that's dropped 5%.
Yeah.
Because they build in these rebates, and the PBMs are able to extract more money from the high cost drug, but it's bad for patients all the way around.
Eddie, we ought to start our own PBM. I mean, you got a case full of PBR back there, don't you? It's close.
He has the opener. We saw that.
Got the opener, right? You're halfway there, man.
Dan, Randy will tell you this opener has never opened anything other than an IPA.
Oh, yeah, he's pretty highbrow over there. Look at him. Look at him.
And we got to be careful about HIPAA laws, because Dale's over here telling everybody on the freaking internet that his blood pressure medication is something called Viagra. I don't get why he's talking about that.
Well, there's always a silver lining, right? So. Hey, there's a lot of stuff. I mean, we could talk healthcare all day in this thing. And you mentioned some terms, and one of them I jotted down is biosimilars. And just some of the cool stuff on the horizon that, there you go. We have
water is in the biosimilars.
I knew that was coming.
We can, there's a innovative, there's a Dr. Robert Atala here in Winston-Salem. It's a regenerative medicine facility. They grow bladders, and they can grow body parts that your body won't reject because it started with your own cells. Just a whole host of things, and they gave me a tour. It's fascinating. They can regrow ears and other parts and organs in the body. So cool stuff coming down the pike. I don't know who monitors that in terms of when it can come to market and at what cost and all of that. But what are biosimilars? It kind of got me curious about that. What are biosimilars?
Yeah, well, if you think of generics as the follow-on to a brand pill, typically, or an oral medication, the generics, and then 10, 15 years ago, we saw a boom in biologic medicines, which are injectable medications. Typically, typically you go to your physician's office or to a clinic or in the hospital, and you're getting an injection, or you're getting a infused medication, right? So those medications are now coming off of patent, so they get this time frame. And biologics typically get longer than generics, but that goes back to Teddy's earlier question. But let's say you're 12 now, you're getting competition. And so a follow on to a biologic medicine is called a biosimilar. It's not an exact replica like a generic, so it has to have a different name. And the reason is that biologics are made from living cells. So every living cell is slightly different. So it is not an exact replica, but they are similar enough that the FDA will approve them. They call them biosimilars. They're bringing tremendous savings to the market. Now we're going to see. I mentioned Humira, and they just happen to be the poster child because of how expensive, how much that is generated. Here's the next question for you. How much do you think Humira generates for its sponsor in 1 year?
Wait, how much they generate for who?
So the revenue for the manufacturer worldwide, actually, no, just in the US, how much revenue has that one drug create?
Oh, it's got to be in billions.
20 billion.
20 billion.
So to put that in perspective, the entire NFL generated 20 billion in revenue last year. So one drug generates more revenue than the entire National Football League.
Yeah, but there's way more people who work behind Humira, the drug, than there are in the NFL. Research, all that, that whole kit and caboodle, whatever that is, I think.
But it's a big number. So now biosimilars are coming to market. As I mentioned, I think 2 are on the market. There'll be 6 before the end of the year. And we'll start to see that.
Does Botox have a biosimilar yet?
You're asking for a friend?
No, I'm not.
I don't know. I don't know the answer to that, Teddy.
I don't know either, but I'm paying attention to that, Dan. So I just, for a friend.
Yeah.
What are just, and I know you're not a physician, but I got to ask you, some of the stuff that you see today, Parkinson's, dementia, Alzheimer's, just some horrible, horrible diseases out there. You mentioned about hemophilia, that we're on the cusp of maybe getting to the bottom of that. We actually had a grade school chum that passed from that. But where are we on the horizon for some of these horrible, horrible diseases from what you can see?
Yeah, I mean, I think we're at an era in an age of great advancement in science and in pharmaceutical science. And, there are, biosimilars, as I just spoke to. We saw in the last 10 years, we've seen cures for diseases like hepatitis C. This may, you'll remember this. It wasn't, it was maybe 6, 7, 8 years ago. Yeah. Hepatitis C, a lot of people have that condition. It had no cure. It was a lifelong condition. Now there is a cure, so we can eliminate, like polio. If the commitment is there, like polio, we could eradicate the country and the world of hepatitis C through basically an 8-week course of treatment. And the cost of that has come down significantly. So that's one, and that's just that's a pill in pill form. Biosimilars, we mentioned. Gene therapies is another area which has got great promise. We've already seen a few gene therapies. These are treatments that literally go in and treat a malfunctioning gene, or in most cases a genetically altered gene. So the first one to go online was for a very rare disease for children who would become blind over time. It was childhood blindness. And now through the procedure and the treatment, gene therapy treatment, those kids will have sight for the rest of their life. Amazing. Hemophilia is one of the next big ones that's coming in the gene therapy space, because that's a genetic treatment. That's a genetic condition,
Mhm.
and will be able to go in and treat and alter those genes. And that's one where you talk about, it's going to be an expensive treatment, but the cost to treat hemophilia now is, in the millions. Transfusions after transfusions, these poor individuals are constantly having to get treatments and transfusions. So, that's going to be a fantastic cure, fantastic treatment when it comes online, and that'll be in the next few years.
We have in a few weeks, Teddy. I'll have to look at because I'm old school. I have a wall calendar here, Dan. So hang on a second. All right, so it's not in July; it's in August. August, right? And he's on the show today. He's watching. John Moskoff's on the show today as an attendee, and we're going to talk about bioethics and some of the hot topics around that, and how he gets interacts with physicians, and whether it's end of life issues and just a whole host of things. And it's fascinating for a layman like me, because I don't know squat about this stuff. And
ask him about CRISPR.
What's that now?
Have you heard that term, CRISPR?
Yep. That's
No.
Without it, a lot of stuff wouldn't be happening.
Yeah.
Yeah.
That is gene editing, which is different than gene therapy, but literally a DNA strand and cutting it and reconnecting it and lots
No
of
duct tape involved, Randy.
What?
No duct tape involved in
None. No duct tape. Huh? Oh, Kentucky Chrome. Well,
there's another one, digital
Yeah.
therapeutics, Randy. I think I talked to you about this. I moderated a day-long summit on digital therapeutics just 2 weeks ago, and that's a relatively new area too. If you think about, everything in our life has been digitized, and so much of what we do, is on your device, on your phone, or on your tablet.
in my
Think
wrist.
about, or on your watch. Yeah, your health.
No, my wrist. In my wrist.
I got or implanted.
Oh,
That's
the
the
chip,
chip in your head that Randy has.
Uh-huh.
But
Never affected me at all.
There are 400,000 health apps that you can get now at the App Store, or you're on your phone, to help you, tell you when to stand or how to breathe or when to walk. But there are a couple hundred digital therapeutics, and there are about a dozen prescription digital therapeutics, but a growing field. And that means that they are FDA approved. They have to be prescribed by a doctor. You go to the pharmacy, and they, instead of giving you a bottle of pills, they give you a code. They give you basically a QR code or a login, and then you go on your device. And we're seeing a lot of this in the addiction space, treatment for addiction, ADHD treatments, opioid disorder, things like that, mental health issues. One that I'm aware of is it's epilepsy. So that's a tracker. For childhood epilepsy, if that child has a seizure in the night, it sends an alert to the parents or to the caregiver. This woman that was on this panel that I was participating in had a daughter. Her daughter has a childhood epilepsy, and the digital therapeutic notified them she was having a seizure. They went into the room. She was face down on her pillow.
Not good.
That's not good. They were able to turn her over, and the seizure passed, and she's okay. So that's potentially a life saved through this one case in this digital therapeutic. So that's a whole other area that's really interesting.
Hey, we've only got about 5-6 minutes left. Teddy and I have a couple of items at the end about talking about next week to take care of. So we've got about 3-4 minutes remaining with you. I'll ask you for a takeaway or two, but I wanted to ask you about if you had a magic wand that you could kind of wave or a crystal ball, whichever is close by on your desk.
Careful request, Randy. The budget is tight.
All right. So you only can pick one, but crystal ball for the future. What do you see is happening here in terms of these PBMs, and where are we headed with this thing realistically? Yeah.
I mean, again, I don't want to, the whole show to be a buzzkill about PBMs. They're a problem. They're a challenge. They're driving a lot of the costs, and it's not necessary. I do think that legislators in states like Ohio has actually been leading on that, and now in Congress are pulling back the curtain on some of these practices. I do believe that we will see change soon. I'm hesitant to put a timeline on it if it's this year
sure.
or in the next few years, and that will that will help overall healthcare costs, in this case drug costs, come down. So I think that'll happen. I'm an optimist.
But based on what you said earlier, Dan, pharma is not the predominant expense in healthcare today.
About 12%.
12%. I mean, they're all big numbers. So it's important for us to manage and get help to manage those costs and have transparency so it's real. But there's a bigger elephant in the room that we're not talking about today.
Yeah. Look, we can get into the politics, and there are politicians there's a reason pharmaceutical companies are an easy target. They're big, typically faceless companies, often headquartered in Switzerland or somewhere else. The list price of these drugs is very high often, and we've learned that list is not what they're making. It's 58% to 75% below list is what they're selling for, but it's really easy to say that the list price is what gets published, so they're shooting at a false target. Hospitals, a lot of great things happen in your part of the world, and RTI and in the hospitals. You can't go by a hospital and not see cranes as they're building new wings.
2 of them in Winston-Salem right now.
Yep. So, but every politician has a hospital in their district, or multiple hospitals, and so it's difficult to go after the expenditures in a community hospital.
Gotcha. Hey, just got a couple minutes left. So real quick, one takeaway, maybe two at most, but something you want folks to really take away from today's talk.
Yeah, well, so when you think about what's going on in the middle space between the drug manufacturer and what it costs you at the pharmacy counter, there's a lot going on there. The more you can understand and learn about it, the better off as a society we will be. So that's one takeaway. And if you're really motivated, call your member of Congress and ask them what they're doing around the issue of PBMs, because it is a hot issue right now, and they will listen to you, and they should listen to you because you elect them. So that's one. And then two, just be positive about the future when it comes to new cures and new treatments, because there's a lot of really exciting stuff coming down the pike. So it's a glass half full, glass half empty story, but all in, I wouldn't want to live in any other country.
Yeah, that's a good takeaway. Dan Leonard, principal of Granite Capital Consulting, has been our guest today. Dan's a longtime friend from years back from our college days, and has been hanging out in the DC area and has had a great career. And Dan, I appreciate you coming on, taking some time today, and best of luck in the consulting gig. If there's anything we can do to be of help to you, please reach out to us. And again, thanks for hanging out with us today. Appreciate it.
Thanks, Randy.
And Dan, thanks for sharing those stories about you and Randy and your college.
We didn't even get started. We didn't scratch the surface.
No. Look at the clock on the wall, Teddy. It's that's
the after show.
We are just out of. I'm sorry, we are out of time today.
Dan, thanks a lot for joining us. I appreciate it. To our audience, thank you very much. To everybody watching us on LinkedIn and Facebook, and who see us on YouTube and the podcast. Love having you. Love sharing these ideas, these stories from our fantastic special guests. Lunch Conversations with Randy and Teddy is sponsored by Blackwell Captive Solutions. We appreciate them helping us and everything they do. Hey, by the way, next week, wait a minute, Randy, where's my info, man? Next week,
Connie Chesner
and Travis Cook, and they're going to come and talk about how does Taekwondo, and another one that I'll butcher saying it, Krav Maga. Go search Google Krav Maga and Taekwondo, and the impact that this has on our lives, and most importantly, our children's lives. You won't believe the power that Taekwondo and Krav Maga can have on our youth in lots of different ways. So join us next week, 11:55 a.m. Eastern Standard Time. Randy, good seeing you. Dan,
man.
take care. And I'll thank you again to our audience and our sponsors. We'll see you guys later. Yeah, Dan, Krav Maga. Thanks.
I'll see you. All right. Bye.
I love you.